Thank you, first of all. I'm coming from America, and so this is such an honor for me to be here in Egypt. I am first-generation American. My family's in back. My mom, who's from Alexandria, is here with me. So for me, this is a homecoming, and it's one of the things I've always wanted to do is to be able to come back and speak in my home country. So this is such an honor, so thank you all. My charge today is to speak on complications of the Latarjet procedure. These are my disclosures. So before I start, since I only have to be here today for my talk, I made a 12-day trip out of this, first starting in Paris and then coming to Egypt, going to Alexandria, and then now Kahira. So for me, this has been just a wonderful trip to find and see where I came from and just really enjoy Egypt. So when we talk about complications of the Latarjet procedure, I think the first thing you need to do is make sure that we're doing the procedure on the right person. We have to have the correct indications because doing any procedure with the wrong indication will lead to a complication. So we first need to understand the type of instability the patient has, whether it's traumatic or whether it's going to be something more like a multidirectional instability. When they're traumatic, these are the ones the Latarjets will do well, whereas when we get into things such as the atraumatic or the multidirectional instabilities, these tend to be more a pancapsular plication that's going to be helpful for those patients. So when we look at this shoulder instability pattern, we're looking at these type 1 traumatic structural ones. But I think it's always important, no matter what you're doing, and when you're examining anybody with a dislocation, whether it be shoulder, an elbow, an ACL for a knee, you need to understand if they're hypermobile or hyperlax. And so the Baton criteria is extremely important to assess on these patients. Without assessing this, you may miss something in these patients that's leading us to say that these are particular patients that may have done better with a different procedure. So when you look at some of these patients, you can see this particular patient has multidirectional instability, and so you can see what her shoulder blade does, and she can do it on both sides. So when you look at something like that, you have to be careful because this patient has a multidirectional instability pattern. Now also when you look at this one, she tells you that I can do this, I can spin my whole hand backwards. That type of patient is not going to do very well with a Latarjet procedure. She's going to need something more soft tissue based and very likely is going to need a recurrent or to do it later in life if you do it early enough with a pancapsular plication. Also, we got to make sure we're not talking about fractures when we're talking about, bony Bankards. These could be glenoid fractures. These are a different type of injury altogether. These are ones that are going to need to be addressed with probably screws or some type of open reduction or even arthroscopic internal fixation. And again, when we see these types of x-rays, this was actually an x-ray sent to me by one of my fellows and said, we have this patient in the emergency department, and he goes, something looks strange about it. And so when I said, can she move her arm? He said, no, she has no external rotation, and it was because she had a fixed posterior dislocation. She had been like this for 6 weeks. And so when she went to the emergency room, this is what we found. So this is not a presentation of a person that needs some type of bony procedure. In her particular case, she was so fixed in this position after 6 weeks, we actually had to do a reverse shoulder arthroplasty on her at 46. And again, when we're talking about dislocations, first dislocation, about 7% of patients will have some type of bony loss. When you have a recurrent dislocation, you're up to about 25%. So we have to make sure that if a patient comes to us telling us they've had 6 or 7 dislocations, it's a high likelihood a soft tissue procedure is not going to be helpful for this patient. This paper came out 2 years ago. This was a near award-winning paper, and what this showed is that there's an 81% increase of bone loss with each additional dislocation. So we have to be careful of this. And then we all know about the instability severity index score. And in America, we don't believe in this for whatever reason. We're starting to change that. But in Europe and the Middle East and even into Asia, this is a very popular way to find out if the patient needs a Latarjet or some type of bony procedure. I think in America, we're afraid of the Latarjet procedure and bony procedures altogether. So what we do is we say this isn't validated, but it has been validated. And therefore, the more you use this, you'll find that there's more patients that will need a bony procedure than a soft tissue procedure. Again, a busy slide, but within this slide, what it tells us is that the Latarjet has fewer recurrences, improved patient-reported outcomes, and more external rotation compared to those of patients that get a Bankart. as you move forward, this is our study that's about to be published in JSES International, which shows that comparing with an arthroscopic Latarjet procedure, comparing their contralateral arm, not injured, to their post-operative Latarjet, there's only a loss of about 5 degrees, which, although significant, seems nominal in the grand scheme of things. And will this really make a difference? But when we're losing only 5 degrees of motion and giving them a stable shoulder, I think this is a better option than a soft tissue procedure. When you look at outcomes after a Latarjet procedure, even if it's a first time or versus recurrent, there's no true difference in recurrence of reoperation between the two groups. However, when you look at some of the other studies, it will show you that higher redislocations rates after arthroscopic revision of Bankart and poor outcomes. What this tells us is don't try to do another Bankart after your first failed Bankart. Go to the soft tissue, or excuse me, go to the bony procedure that is going to help this patient. Again, looking at this and stating that when you look at the study of failed Bankart versus primary Latarjet, a Latarjet after a failed Bankart is not equal to a primary Latarjet. So if that patient has multiple dislocations, has bone loss, don't try to do the Bankart first and say if it fails, then we do a Latarjet. Those patients actually do worse. You go directly to the primary Latarjet, and that's when you get a better outcome. Ongoing, you see that many people will say, well, it's such a big problem, this procedure. Well, it's a salvage procedure in most cases. These patients no longer have their original anatomic bone stock. So what do we have to do? We have to restore it somehow, whether it be with a bone block or whether it be with the coracoid. But the recurrent dislocation rate is about 9% with a primary Latarjet and over 20% with a salvage Latarjet after failed other procedures. So again, primary Latarjets are going to be better than a failed Bankart. But now we're going to talk about Latarjets. Now you're doing everything perfect. Everything is going great. And you feel like $1 million. You're doing everything you want. Well, here come the complications. So now what are those? So these are the contraindications. Again, going off of what we've done and what we said before, we can't do these on patients with massive irreparable rotator cuff tears. You can't do them on traumatic dislocations in older patients with rim fractures or voluntary anterior dislocations. These are the MDI patients, or uncontrolled seizures or unstable, painful, and even microinstability. Any type of prosthesis you can't do this with. Locked anterior and posterior dislocation, and then the inferior subluxation like a luxatio erecta. Those don't work with these. So when you look at the overall numbers, and Jill Walsh had this great study that showed us these complications, and what it showed is that if you look at recurrence, it's only about 3%. If you look at infection, only about 1.5%. You can see the numbers here. The biggest problem is osteoarthritis. What is the biggest issue we're dealing with? Instability. Instability without treatment will lead to osteoarthritis. So our goal is to slow the progression. It's not going to reverse the progression of arthritis. So I don't necessarily think that the continuing osteoarthritic changes of a shoulder that's unstable are really a true problem. I believe that this is a secondary sequelae of the underlying instability. Again, when we look here, complications, about 16%, reoperation rate about 3%. So again, there's going to be these numbers that we're going to see over and over and over again. But again, remember, this is a salvage type procedure. We're going to see complications with this, as usually this is they've had multiple problems, whether multiple dislocations or even multiple surgeries. So they're going to have issues that are going to require them to have more procedures in the future. Again, one of the things that was brought up earlier about positioning of the graft, complication rate in this study was about 11%. And when you medialized it, what was interesting about this is the recurrence rate was about 100%. So if you medialize the graft, it doesn't work. But the other problem is if you lateralize the graft, it had a 250% increase in arthritis. Because what happens if you lateralize it, every time that humeral head comes by, it scratches again, more cartilage off. And over time, that lateralized graft will not work. Again, a busy slide, but the takeaway here is about, in the first 90 days, you're going to see about 9% complication rate. Most often, it's going to be a neurologic issue. So one of the things we got to look for is our positioning of our screws. We can't have too big of a divergence with those screws. As what we want to make sure is that we're more square and straight, and we don't want this divergence of our screws or these steep screws here where that beta angle increases significantly. Again, in this particular study, 90-day complication, about 7.5%. So we're starting to see very similar numbers. So we can do the CT planning. If you have this, you can see that you know what these two numbers are. And so with those two numbers, the width of your graft and the width of your glenoid, you can then figure out how long your screw should be and essentially pre-plan your procedure. And in doing so, make sure that you're within 5 millimeters of that posterior cortex so that you're not by the spinal glenoid notch, which is where your suprascapular nerve is, and that will prevent injury. Sometimes, however, you may have patients that complain of hardware. This is a patient that after a Latarjet, I went back in and I took out her screws. She had no issues with instability. Her problem was that the screw was bothering her. And so it was actually abrading the undersurface of her subscapularis. So we took her screw out. She had no further issues with that. Again, when you look at open versus arthroscopic, the numbers are about the same depending on whose hand you look at. And so when you compare these studies with one of J.P. Warner's versus Matt Ravenscroft in Manchester, England, you can see the numbers are significantly better with arthroscopic Latarjet. I've debated Dr. Lauderman, who has gone away from the arthroscopic Latarjet and back to open, but I think that with continued proficiency with arthroscopic, you're going to see a significant decrease in opiates. You're going to see a significant decrease in complications as well. In our own study, 51 patients, our overall revision rate was about 7%. Of the first four complications we had, they were in my first 25. So that learning curve of about 25 patients to do an arthroscopic Latarjet seems to be appropriate. And after that, we haven't not had that many. And I think we're up to about 86 arthroscopic Latarjets since 2015. So the hardware failures you'll see, these are the ones that you are concerned about. But again, I think with better instrumentation these days and better screws, you're not seeing these types of issues as we once saw. Again, 45 patients here, and this is the famous J.P. Warner paper from 2012, 25% complication rate, most of which were neurologic. I think it's also important when you look at combined loss, you need to make sure that you address both the humerus and the glenoid, because if there's a large glenoid injury and humeral injury, this bipolar injury will need both sides addressed. So it's important that we address those two. Long-term issues, 5.9% recurrence with a Latarjet, but again, 20% arthritic progression. And we talked about that. That's going to happen. We know that that's an issue. My dear friend Ivan Wong in Canada is a big proponent of using a distal tibial allograft for a bony procedure instead of using the coracoid. He's found great work, and he showed this, and he put a side-to-side study together comparing screw and button fixation. Button fixation seems to be a big trend these days. And so one of the things he noted, though, is in the buttons, he had a 39% failure rate. And many of those is because the buttons loosened up, the screws did not. So it's very careful. If you want to do this procedure, be careful of doing it with buttons. Finally, the graft position, we talked a little bit about this. It's kind of like Goldilocks, and so this one was too medial, this one was too lateral, and this one was just right. So we got to make sure we take the time to appropriately position it, because that's the whole procedure. 51 patients here. When you look at the graft and the appropriate positioning, not only did you have better outcomes, but you also had, with the arthroscopic procedure, had a decrease in the opiate use. So there is a proponent here of doing this arthroscopically. When do I return them to play? I get a CT scan at 3 months. If I see healing, then I can let them go even back to collision sports. I think this is going to be the way that we prevent this in the future. This is one company that will be able to take a 3D model of the shoulder, and we can appropriately position this and look at our bony bone loss and figure out how much we need and do this for every patient. And we're already getting the CT scans anyway, so this will be a great way for us to, in the future, do this. So in summary, I want you to understand the patients, the type of instability, have the correct diagnosis. Again, remember, primary Latarjet is better than revision Bankart. Arthroscopic versus open. The debate is still ongoing, but I think in the future, as we've seen with rotator cuff, mini open has gone away and it's arthroscopic now. I think we'll see the same thing with bony instability. And again, remember, this is higher complication rates because of the salvage procedure. While I'm here, I want to also just bring up to you, each and every one of you, I sit on the ANA International Committee for the Arthroscopy Association of North America. I would love for each and every one of you to become a member. This is a partner course with ANA. I think this would be great because we have a mission and vision that I think correlates with EGAA. We have 5,500 members, 80 countries, and it would be great to include this international community, my own international community of Egypt. So I think it's really important that I bring that up to you. And then it's only $150 US to join, but you can go right to the ANA website. And then a little bit from the standpoint of, oops, can we go back for 1 second? I have one more slide. Yeah, that's the slide. Perfect. And I've seen some great videos during this meeting. I sit as the chair of the Orthopedic Video Theater Committee for the American Academy of Orthopedic Surgeons, the AAOS. I would love for each and every one of you that makes videos to turn in these videos for awards. We do these, we give the awards at the Academy meeting next spring, and that one will be in Las Vegas in America. So I would love to invite each and every one of you to turn in our videos. And again, video.AAOS.org. And over here on the far right, Reese at AAOS.org. She's, if you have any questions. Thank you so much.